Welcome back. Bradycardia is one of the most misleading calls in the field, because the number can look terrifying and mean nothing. And the opposite is also true. A rate that doesn't look that low can be starving the brain and coronaries. So here's the rule that keeps you honest. We don't treat bradycardia. We treat perfusion failure. That's the whole call. Your first question is not what's the heart rate. Your first question is this low pulse harming the patient? Yes or no? If the patient is talking, alert, warm, and perfusing, don't chase a number. But if the patient is deteriorating, bradycardia stops being an ECG problem. It becomes a circulation emergency. Cardiac output is not magic. It's simple math. Cardiac output is the heart rate times the stroke volume. A healthy person can compensate for a slower rate by increasing the stroke volume. That's why athletes can sit at 45 and look perfect. But compensation has limits. When the rate drops and stroke volume can't rise enough, output drops. And when output drops, perfusion drops. That's when slow becomes symptoms. Less cerebral flow will cause confusion, syncope. Less coronary flow will cause angina-type pain. Less flow can cause backup into the lungs, can cause a pulmonary edema. So that's drop in pressure takes the patient into a shock state. So bradycardia isn't about slow, it's about delivery. Oxygen delivery to tissues right now. If the patient looks sick, you take control of basics first. Get them on full monitoring. ECG, saturation, blood pressure, and if you have it, capnography. Not because it's nice, but because you are trending perfusion, not guessing. Now oxygen, but with intent. If the respiratory distress or saturation is under 94%, correct hypoxia and target saturation to above 94%. And now the move that prevents a classic miss. Get a 12-lead ECG when the patient condition allows. Because inferior ischemia can present as bradycardia. And if you suspect an inferior wall ischemia pattern, don't be lazy. Run right-sided and posterior leads when appropriate. While you are doing this, your brain is already scanning reversible causes. Hypoxia, medication effects, ischemic conduction failure, and metabolic problems, especially hyperkalemia. Because treating the rate without treating the cause is how patients respond, then crash again. Now you make the decision explicitly. Symptomatic bradycardia is not slow and uncomfortable. It's slow with evidence of poor perfusion. So you're hunting danger signals. Chest pain compatible with ischemia, altered mental status, systolic pressure under 90 or clear hypoperfusion, pulmonary edema or respiratory failure picture, any new neurologic deficit suggesting the brain is underperfused. If those are present, this is active treatment territory. If they are not present, you still don't relax. You continue monitoring. You trend vitals, obtain ECG, and transport with a deliberate plan. And here's the high-level move. If you suspect a high-risk conduction problem, place pacing pads early. Not because you must pace now, but because if they deteriorate, you don't want to build the setup from zero. Some brady patients are stable for now, but unstable by design. If the ECG showed advanced AV block, especially Mobitz 2 and above, the problem is often below the AV node. That's conduction system failure territory. So even if the patient looks not so dramatic, your posture changes. Tight monitoring, pads ready, and rapid transport. Because these patients can flip from okay to no output, fast. Quiet doesn't mean safe. It just means you still have time and you should use it. If the patient is symptomatic, you can start with atropine. But atropine is not heart stimulant. It's parasympathetic blocker. It removes the vagal braking at the SA and AV nodes. So it works best when the problem is nodal and vagal driven. Here's the clinical truth you need to hold in your head. Atropine is often ineffective in high-grade blocks, especially Mobitz 2 and above, because the problem isn't vagal tone, it's conduction system failure. So you give atropine cleanly, and you don't let it delay your plan. You give atropine in a dose of 1 mg IV push, and you can repeat every 3 to 5 minutes as needed, maximum 3 mg. And while it's happening, you're already preparing your next step, because waiting passively is how perfusion dies. Now, if the patient is still symptomatic, or the ECG tells you atropine is unlikely to work, you move. Your goal is not pretty numbers, your goal is perfusion. So you bridge. You have two options. Option 1, epinephrine push doses. It's fast, controllable, useful while you are building the pacing. 10 to 20 microgram IV push, repeated in intermittent doses as needed per your system, while you trend perfusion. Option 2, dopamine infusion, titrated to effect, 5 to 20 microgram per kilogram per minute. And the mindset is critical. Pressors are not the ending, they are the bridge. The bridge to pacing when conduction failure is the real enemy. External pacing is not a last resort. In the crashing Brady patient, it's often the most direct way to restore output. But pacing done sloppily is painful, chaotic, and sometimes ineffective. So you pace with control. Step 1. Airway and ventilation readiness. AMBU ready, suction ready, and airway adjuncts ready. Because sedation and deterioration can change the airway fast. Explain what's happening. Draw up sedation. If the patient is conscious, you don't just pace, you sedate first. The sedation anchor is ketamine 0.5 to 1 mg per kilogram IV. If blood pressure allows and you want additional anxiolysis, midazolam 2.5 mg IV only if hemodynamics tolerate it. Position the patient normally. PEDs go anterior, posterior. And here's the practical warning that prevents the classic mistake. The pacing screen starts pacing immediately, so you do not enter the screen before sedation and readiness. Now you pace with the system, not vibes. The patient is fully monitored. Saturation, blood pressure, and capnography is a major advantage. Set intensity initially to about the patient's weight in milliampere. 70 kg patient, start around 70 milliampere. Keep frequency to default, around 70. Now hunt capture in 2 steps. First, electrical capture. Every pacing spike should produce a ventricular complex. If not, increase intensity by 10 milliampere. Reassess and repeat until you get consistent electrical capture. While the first step is complete, you go to the second step. Mechanical capture. Because electrical capture is not enough. You must prove output. You confirm mechanical capture by a palpable pulse, femoral, radial, or in kids you can feel the brachial. You see improving color and mentation. You see rising of end-tidal CO2 if you're tracking it, a pulse oximeter rate that matches your pacing rate. If you have electrical capture but not mechanical capture, you are not done. Increase milliampere in steps of 10 until mechanical capture appears. Once you have both, add a safety margin. Increase another 10 milliampere above capture to secure pacing. Now you reassess like a clinician, not like a technician. Full ABC check. Is the airway still patent? Did sedation drop tone? Do you need jaw thrust or an adjunct? Is ventilation adequate? Is perfusion improving? If ABC looks good, but blood pressure is still low, you have levers. Raise legs if you haven't. Increase pacing rate gradually. Go to 80 and check blood pressure. If it's not helping, go to 90 and check blood pressure. up to about 90 to 100, reassessing each step. If pressure still does not respond, bridge with pressors, epipush and or dopamine, as we said before. And if your hypoperfusion pathway allows it, and there is no pulmonary edema, consider fluid boluses as an hypoperfusion protocol entry point. And remember, pacing failure isn't always operator error. Common causes you must think about is hyperkalemia, acidosis, hypoxia, a dead myocardium, expired or defective pads, poor pad contact, wet skin or heavy hair, so you correct what you can. Dry, shave, press firmly, replace pads if needed. And think about treating the underlying metabolic problem if that's what blocking capture. A low-level Bradycardia is heart rate was 38, we gave atropine. A high-level Bradycardia is we identified perfusion failure early. We corrected oxygenation to a saturation above 94% when indicated. We obtained a 12-lead ECG and treated the rhythm in context, including inferior ischemia traps. We used atropine correctly without letting it delay the plan. We bridged with epinephrine push doses and or dopamine when needed. And we paced deliberately. Sedation, electrical capture, mechanical capture, safety margin, and reassessments. And we understood why pacing can fail. And we fixed what we could. So if you carry one line into the field, make it this. In bradycardia, your job is not to raise the heart rate. Your job is to restore perfusion and prove that you did. Thanks for listening.